Akarsh Agarwal is there? Yeah, please come. He will be presenting on the catastrophes of an implant malposition.
And speakers or presenters must remain here to
Yeah,
face little bit of, we don't
discussion.
grill you, we just
Discussion.
teach ourselves that you read it more than I have read. So you know it more than me.
Good morning, everyone. I'll be walking you through our case of titled Catastrophes of an Implant Malposition. There are no financial interests. So a 34-year-old male had presented to our OPD with complaints of diminution of vision in the right eye for last 1 year. And the only significant history was he had a titanium mesh implant for an orbital roof repair was done following an RTA 12 years back. So on examination, vision in the right eye was reduced 6/9, left eye was 6/5. Color vision was normal and Hertel's was comparable. So on primary gaze, he had a 5 prism diopter L over R. On up gaze, he has a -3 elevation limitation, and the squint was a 20 prism diopter L over R. Down gaze and lateral gazes were all normal. He had a lag of ophthalmos of 3 millimeters. He had poor bells, and you can clearly see in the cornea signs of exposure keratitis. So a CT scan was done, and we could see the original implant was impinging on the globe, as well as the LPS was noted to be thinned out. So a diagnosis of right eye implant malposition abutting the globe was made, and the patient was planned for right eye implant trimming via lid crease approach until general anesthesia. So intraoperatively, we noted that FDT was restricted superiorly, and the titanium mesh was seen abutting the globe superiorly, and there was extensive adhesions and scar tissue present. So we removed 4 small islands of the implant. So this is preoperative. You can see the patient, and this is post-op photo. This is at 1 year follow-up. The patient is now orthophoric. The lag of ophthalmos is completely resolved. His up-gaze motility restriction is also resolved. He has now good bells, and his cornea, you can see it sparkle. It's totally clear, and he has now 6/6 vision. So orbital roof fractures are rather rare, comprising of 1 to 9% of orbital wall fractures, and 60% of patients usually require surgical repair, with titanium mini plates being the most commonly used implant in 46% patients. Some common post-op complications include some post-op edema, chemosis, vertical movement limitation, enophthalmos and exophthalmos. As per our knowledge, this is the first case to be reported in which a patient developed poor bells due to direct impingement of the globe by the implant. A review of literature was done which showed that around 6.5 to 17% patients post-implant require revision surgeries due to a variety of complications which I previously mentioned. And in most cases, the surgery or revision surgery is done within 2 months. But in our case, the patient presented after 12 years of his primary surgery. So in conclusion, we need regular follow-up post-implant surgery to look for implant-related complications. Patients can present late in case of elevation limitation, as did in our case, because they are able to manage their day-to-day activities, as the patient did not have any diplopia in primary gaze or on down gaze. So they are able to go about their daily lives without much difficulty. Impingement of the implant over the globe can alter the Bell's phenomena, as it did in our case, and this can further lead to exposure symptoms. And thorough clinical examination and imaging helps clinch the diagnosis and appropriate management. Thank you.
Yes. So definitely this displacement of implants is a big problem in such cases, and wherever you have to cautiously place and monitor the patient regularly. Otherwise, not just merely doing the surgery and just forgetting the follow-up of the patient. So patient can end up with problem which we had already now seen.